Thanks so much for joining. We're going to give it just another minute or two, and then we'll get started. All right. Well, I think we'll go ahead and get started. So welcome everyone to the fourth day of the 2021 Virtual SMA Conference. This is Jessica from Cure SMA's Family Support Department, and we thank you all so much for joining us for the Early Scoliosis Management and SMA session today. We are so grateful to our national presenting sponsors, Biogen, Genentech, and Novartis Gene Therapies for their incredible support of this year's Virtual SMA Conference. I did want to note that all lines are muted during this session other than for the speakers. But if you do have any questions, you can find the chat conversation tab located on the right-hand side of your screen. You can use this to submit questions throughout the session, and we will try to answer as many of these as we can. We have some time at the end for the Q&A portion. And now we would like to introduce our speakers, Dr. Rosenfeld with Chalk Children's Hospital and Dr. Snyder with Boston Children's Hospital. Dr. Snyder?
Hi, thank you. So this is a little bit of a continuation of the presentation Sam and I did yesterday, with now a focus on early scoliosis management. And what I'm going to try to do is go through why we get so concerned and why we're pretty aggressive about trying to manage early scoliosis, what the physiologic implications are, and then what some of the non-operative and operative solutions are. These are my disclosures. So early onset scoliosis is defined by the Scoliosis Research Society as scoliosis or spine deformity before age 10. It's common in SMA 1s and 2s, and it's a multiplanar deformity affecting both the coronal, which is the front plane, sagittal plane, which is the back side to side, and transverse plane, which is the plane through your trunk. The more severe the weakness, the earlier the onset and more progressive the deformity. And it's classically the C-shaped thoracolumbar curve, where you can have associated pelvic obliquity and kyphosis, which is curvature in the sagittal plane. The issue really here is the associated rib collapse, and that leads to thoracic insufficiency and restrictive lung disease. The consequences of a progressive scoliosis are compromised sitting posture and balance, and then the cardiopulmonary compromise with restrictive lung disease, and then actually compression of the heart called right heart failure or cor pulmonale. Thoracic insufficiency syndrome is an extrinsic restrictive lung disease defined as the inability of the thorax to support normal respiration or lung growth, and then it results in what we call a postnatal, meaning after birth, pulmonary hypoplasia, meaning the lungs can't develop normally. So normally in a growing thorax, the rib cage must enlarge for lung growth, and the rib cage provides the width and the depth, and the thoracic spine provides the height. So if we look at this 4-year-old with early onset scoliosis and a CT scan transaxially through the chest, you see compared to a normal 4-year-old, how much less room there is for the lungs to grow and to breathe. So failure of the thorax to grow causes an extrinsic restrictive lung disease. And normal growth of the lung and thorax are interdependent. So from birth to age 8, we undergo alveolarization, where the air sacs that have the exchange of oxygen and carbon dioxide from the blood take place directly. But after age 8, that alveolarization process ceases, and after age 8 on to maturity, essentially the only thing that happens is the alveoli get bigger. So interventions to correct early onset scoliosis to prevent thoracic insufficiency should be undertaken ideally before age 8 years old. And then diaphragmatic mechanics, the diaphragm functions as a piston, and it accounts for 85% of the change in thoracic volume, where the rib cage functions as a bellow and accounts for about 15% of overall ventilation. Pulmonary function varies with thoracic volume as well as the height and length of the spine. Pulmonary function tests are typically reported as percentiles based on height that are measured either standing or sitting. However, normative percentiles in SMA are meaningless because our children have scoliosis that affects the normal height of the spine and contractures that affect the actual standing height or even supine height. So often then what's used as a surrogate is ulnar length or pelvic inlet width. So in the study that we did of our children, where we looked at children with a Cobb angle, that's the curvature of the spine, under 50 degrees, and we used pelvic inlet width as a height surrogate, pelvic inlet width accounted for 74% of the variation of forced vital capacity, which is one of the primary metrics of pulmonary function tests. Whereas Cobb angles greater than 50 degrees, that means more severe deformity, there was no correlation. What this means is in children with SMA with moderate spinal deformity, pulmonary function varies proportionately with the change in height that occurs with growth. However, for severe scoliosis, meaning a Cobb greater than 50 degrees, the pulmonary function was unable to change in proportion to the change in stature, and that's defined as thoracic insufficiency. We also described the associated rib deformity that hypotonic children with neuromuscular scoliosis often exhibit. We call this the paracel rib score. And what we showed was that the paracel rib score predicted the need for assisted ventilation with a cutoff of 0.56, predicting the need for assisted ventilation with 73% sensitivity and 100% specificity. The first question that we had then, does treatment with nusinersen then actually mitigate the pathoanatomy in SMA? So we did a multi-center retrospective cohort review, including two big tertiary centers, Boston Children's Hospital and Children's Hospital of Philadelphia, 87 subjects with SMA2 treated with and without nusinersen, and we compared them in their matched groups. So we looked at sorting at about an age 4, followed for 7 years with consecutive spine radiographs. And what we found was that the nusinersen treatment group tended to be younger and tended to have smaller curves. However, there was no statistical difference between the treated group with nusinersen versus non-treated in terms of curve progression, paracel rib deformity, need for respiratory assistance, or need for surgical intervention. The treatment goals of spine deformity is to have a balanced spine with the head over the pelvis, a level pelvis with symmetric pressure at the buttock, and to prevent progression of the deformity with the goal of improving sitting balance and tolerance so that we can eliminate use of upper extremities for support, decrease need for assistance, but most importantly, improve pulmonary growth and function. For correction of the spine deformity, we're essentially applying a corrective bending moment, and this can be done either internally using surgical instrumentation or externally using braces. So the treatment options non-invasively are meta-body casts, and while these are used for babies with early onset scoliosis, these are really too heavy and restrictive for safe use in children with SMA. The thoracolumbar sacral orthosis, or sometimes called TOSO, is thought to slow progression. It's been shown to be quite effective in the teenager adolescent idiopathic scoliosis, but its efficacy in neurogenic scoliosis is yet to be proven. And then there's invasive spinal instrumentation, either using growth-friendly devices, which are internal splints that partly correct deformity, decrease curve progression, and allow for spine and thorax growth. And then there's spine fusion, which is definitive correction of the deformity, but this halts further spine growth. And we generally do this in children older than about age 12. The semi-rigid alloplast TOSO has been around for 40 to 50 years. It's a custom molded brace. It's important to have an anterior window for abdominal breathing and G-tube. What we want to do is apply a corrective lateral force at the apex of the curve and then also distract axially to partly correct the deformity with anti-kyphotic moments applied anteriorly at the sternal notch and then posteriorly down at the mid-thorax at T9, which acts as the fulcrum point. Our hypothesis was that the TLSO will delay progression of the scoliosis and improve sitting posture and tolerance. However, when we did a retrospective review of nearly 80 patients, we found that bracing did not mitigate scoliosis. However, spine bracing did improve function, and we did a retrospective review of type 1 and 2 SMA treated with the TLSO compared to those not treated with the TLSO, looking at the Hammersmith Functional Motor Scale, which is a disease-specific gross motor functional test. And what we showed that bracing does improve functional ability, where the non-brace patients actually lost points. The brace patients maintained or actually gained points. And specifically, we saw improvements in crawling. The limitations of this study was the bracing compliance was not objectively measured. We know for idiopathic scoliosis patients, time in the brace is equal to the dose of medicine, so to speak. And you need to have 15 hours for efficacious use. But most SMA patients are only using the brace when standing gait training or using it as an assistive device during sitting activities. We also did not measure pulmonary function, where the work of breathing may actually be decreased in the brace because an upright posture allows better diaphragmatic excursion. So our follow-up studies will actually try to focus on compliance and actually do we improve breathing. So the take-home points for this are spinal orthotics are palliative, not preventative. They did not slow progression, but they did maintain or improve functional status. And we also think it can be used as supportive seating in lightweight self-propelled wheelchairs. So what are the indications for spinal surgery? If the expected benefit outweighs the negative consequences of the natural history and the surgical risk. So progressive scoliosis greater than 50 degrees, difficulty with seating, failed attempt at bracing. You have to have adequate hip range of motion for sitting and a stable medical status, both nutrition, pulmonary, and bone quality. Axial skeletal deformity can be caused by deformity above or below the pelvis. So above the pelvis is scoliosis, but this can often include the pelvis and contribute to pelvic obliquity. Intrapelvic deformity can be cause of asymmetric hip dislocations. And infrapelvic deformity can be caused by contractures of the hip flexors and the hamstrings. So basically, before moving forward with instrumenting the spine, you do want to address intra and infrapelvic deformity by addressing contractures and hip dislocations. Growth-friendly devices are indicated for a child less than 10 years old with severe scoliosis unresponsive to bracing. It's equivalent to an internal splint. And it's a non-fusion technique where we span the entire curve length and we have anchors 4 to 6 above and below. And these anchors can either be to the ribs, and that's the so-called vector device, the spine, and the pelvis. The rods are inserted above the muscles under the skin, and dual rod constructs have been shown to enhance stability. The rate of growing the rod depends on the system used and whether you're using the magnetic devices, traditional, where you have to physically go in and lengthen every 6 months, or the vector device. Sam is going to talk to you about a novel technique that he's developed where it allows the normal growth of the spine to take place by sliding along rods that act as tracks. Often for severe scoliosis, we'll have to do a stage procedure where we'll first do some preoperative halo gravity traction for about 3 or 4 weeks with the goal of reducing the scoliosis to make the surgery easier. And then we'll do a dual rod multisegmental fixation, and we can get quite nice correction as you see in this case. Technical considerations are intraoperative halofemoral traction, where the femoral traction is applied to the concave side. Dual rod multisegmental fixation helps disperse the corrective forces and moments over several anchor points. So we'll typically use either sublaminar wires or bands, hooks, or pedicle screws, which allow for better 3-column fixation and better correction. We'll do instrumentation above the muscle layer, except at the proximal and distal anchor points, and we'll typically do 3 vertebrae above and 3 vertebrae and or the pelvis below to have a stable foundation. If the pelvis is part of the curve, we include it in the construct to prevent so-called crankshaft, because as the child's growing, what can happen is the pelvis can actually spin off the construct if it's not included. And then to accommodate access for Spinraza, we make a small window at the L4 level so that you can have your neurosurgery team or neurology team continue to do intrathecal administration of Spinraza. We like to use antibiotic beads or vancomycin powder in the wound bed to help decrease infection risk. The sagittal plane is as important as the frontal plane correction to facilitate head control and sitting balance. And you want to set the thoracic kyphosis to bring the C7 plumb line through the hip joint. And you want to avoid proximal junctional kyphosis, which as you see in the picture of this individual, where essentially their head is in their lap. They're basically, their neck and their head have fallen off their spine. So you want to instrument above the upper vertebral level of the thoracic kyphosis. Typically that's above T4. And if the cervical thoracic junction is deemed to be unstable, we'll actually extend using bands up into the cervical spine, using a construct that allows the cervical spine to continue growth, sliding along the rods. The so-called growth guidance technique, or Lukey trolley, Sam's going to talk to you about in more detail. In children with low muscle tone, hypotonia, we actually have to increase the lumbar lordosis a little bit greater than normal to about 45 degrees to help compensate for weak gluteus maximus and core musculature and to avoid pressure on the coccyx and ischium during sitting. Now, when we instrument to the spine, we're actually changing mobility and hip stability. So normally in standing, you have increased lumbar lordosis and anterior pelvic tilt, and then sitting, the lumbar lordosis decreases and you have posterior pelvic tilt. When we instrument to the spine and pelvis, we're actually fixing that and eliminating it. We don't have the posterior pelvic tilt normal in sitting posture. So if you have a dysplastic acetabulum with posterior deficiency, which is common in these children, you increase dislocation risk. So because hip instability and spine deformity are often concomitant, what we will do is fuse the spine or instrument the spine first, but noting that you require a mobile hip for sitting. And then what we will do is fix both hips once we've stabilized the pelvis in a neutral position. Thank you again for our sponsors. And now I'm going to turn the rest of this talk over to Sam.
Thank you so much, Dr. Snyder.
Good morning. I want to thank the conference sponsors. I want to talk about guided growth in segmental spinal instrumentation and my 20+ year experience with this technique. I don't have any conflicts with this presentation. Guided segmental spinal instrumentation in early onset scoliosis can result in growth and correction of the deformity. Dr. Snyder beautifully outlined why we like to avoid any intervention, but on these children with early onset scoliosis that are having progressive deformity, we would like to do something that instruments the spine without fusing the spine. And I want to share my experience with 20 consecutive patients that underwent this segmental spinal instrumentation without fusion from 1998 to 2013. 10 of these patients were spinal muscular atrophy, 4 with type 1 and 6 with type 2. The mean age of surgery was 6 years and 8 months. And on average, 15 spinal segments were instrumented. and there was no postoperative spinal orthosis utilized. The surgical technique involves a standard posterior approach, and the spine was exposed subperiosteal just to the facet joints, which were preserved, and sublaminar cables were passed at each level. I used 2 paired stainless steel unit rods that were cut and contoured for maximal curve correction, maintaining normal sagittal to side alignment, and these were secured to the ilium. Crosslink was placed at the caudal end of the construct, and the cephalad, the top portion of the rods, were left long to allow spinal growth along the construct and obviate the need for further lengthening surgeries. And again, postoperative bracing was not utilized. Radiographs were evaluated with this SurgiMap spine software, and we were looking for correction and maintenance of the deformity, the spinal growth from thoracic levels 1 to 12 and from thoracic level 1 to the sacrum. We looked at proximal junctional kyphosis and any evidence of hardware failure. The average follow-up for these 20 patients was over 8 years, and all the patients had at least 5 years of follow-up. That first graph demonstrates the preoperative deformity of the spine, the postoperative correction and maintenance of that correction. And the most important part is the lower graph, which demonstrates the growth of the spine from T1 to T12 and from T1 to the sacrum. And in the spinal muscular atrophy patients, the T1 to S1 growth was 1.5 centimeters per year, which is a normal growth rate for the spine. There were complications including 4 additional surgeries and 3 patients for infection. There was 1 failure of pelvic fixation from a motor vehicle accident and 1 implant failure in a spina bifida patient, but that was after 5 years. So that child went on to an uneventful spinal fusion at 13 years of age. So the instrumentation accomplished allowing the spine to grow until he was 13. These are just some examples of a type 1 SMA patient that was done. I left the date on there. This was done in 1998. The rods were left long, and 20 years later, you can see how the patient grew off the end of the spine. It did not prevent the paracel rib deformity that Dr. Snyder talked about, but it did maintain normal sagittal alignment. And you can see a 20-year follow-up. She's at the end of her rods here, and the sagittal alignment has been maintained. Another patient with type 2 spinal muscular atrophy that has 16 years of follow-up. And you can see the rods are left long here, and at the end of 16 years, she's grown well beyond the end of her instrumentation, and again has maintained very nice sagittal alignment. Another patient with type 1 spinal muscular atrophy that has 15 years of follow-up. Again, you can see that the rib deformity was not altered or did not prevent the rib deformity, but again, sagittal alignment was well maintained, and you can see how this patient has grown off the end of the spinal instrumentation. Another patient with type 1 spinal muscular atrophy with 12 years of follow-up, showing how the spine has grown and maintaining the sagittal alignment. So segmental spinal instrumentation without fusion is an effective procedure treating these spinal deformities that have early onset scoliosis. So scoliosis correction and sagittal alignment were maintained while allowing for continued growth without the use of external immobilization. None of these patients exhibited progressive restrictive pulmonary disease during the treatment. And what I mean by that, there was no change in assisted ventilation in any of these patients from preoperative to their final result. And the complications that we had did not interfere with spinal growth or compromise the instrumentation. So guided segmental spinal instrumentation without fusion is well tolerated and an effective surgical technique that avoids the morbidity associated with multiple surgical interventions in these early onset neuromuscular scoliosis patients. Thank you very much.
Wonderful. Thank you so much, Dr. Rosenfeld, for sharing, and Dr. Snyder as well. Dr. Rosenfeld, if you could stop sharing your screen, I'm going to have both you and Brian, perfect, join us for the Q&A session. So we're going to move right in. We've got a few questions coming in for both of you. So our first question for you is, does the pulmonary issues related to scoliosis also increase secretion issues and or the need for suctioning?
Yeah, that's a great question. So the secretion issue actually has less to do specifically with pulmonary, like in terms of thoracic insufficiency. A lot of our kids have difficulty managing their secretions. When your head's in your lap, you know, basically what happens is you can't hold your secretions and they kind of just drain out. On the other side of things, when you sort of are in an upright posture, some kids can actually have some difficulty with swallowing and can actually have some aspiration related to that. Often, what we've done in some of these kids have tried to do some drying agents. You can do Botox to the salivary glands to help diminish some of the secretions. They're sort of related issues, but separate. Generally, I think you guys have maybe heard some of the talks from Rob Graham. He has a bunch of strategies to try to deal with that. In general, what we have found is an upright posture, either using a brace or after spine surgery, is in generally benefited swallowing and management of oral secretions. Sam, do you have any insights as well?
No, we can often see some reflux problems and increased secretions even after surgery, because the scoliosis often can actually prevent some reflux, and straightening the spine can actually increase the reflux. So we need to be careful with these children and monitor that closely.
Great. Thank you both so much for addressing that question. I did want to point out, if you do have questions, please feel free to use the chat while you're watching this, session. Our next question for you both is, are there many cases in which the patient gets a spinal fusion as a young teen and later has another surgery to straighten the spine and pelvis even more?
Yeah, that's a great question. So part of the reason in the growing spine that I do now goes and includes the pelvis is prior, when these growing rod techniques were first developed, the teaching was to try to stop short of the pelvis if it wasn't part of the curve. The problem is that you had continued growth, and while you had a straight spine, a lot of the kids would what we call crankshaft, meaning you had continued growth, but the few segments or instrumented segments were a little bit tethered, and then you would kind of torque off or spin off above and below. For that reason, we've now pretty consistently included the pelvis, and I'll often go up to T2 or occasionally up to the cervical thoracic junction in an effort to prevent that as a late complication in young adulthood. A bunch of the children that I took care of 20 years ago who are now young adults were actually having to do some revisions of extending their instrumentation up higher and lower. So especially if you have a pelvic obliquity in excess of 15 degrees, it can actually start interfering a little bit with seating. Sam's construct, if you know, it pretty consistently includes the pelvis to help prevent that as a complication. But many children 20 years ago, we didn't quite know that, and we've learned that lesson a little bit through experience. But the revisions can be done. They can be done safely. They are a little bit technically challenging, and you want to make sure that you have a spine surgeon who has experience doing these type of revision surgeries. It can be a little bit of a technical challenge.
The other issue is that you see these metal rods in the spine and you think they're strong, but they're nowhere near as strong as a normal spine. So all of these early onset scoliosis surgeries were really designed to be revised as a teenager when you're done most of your growth and do a formal fusion. Most of these, the parents have to understand that often that the surgeries need to be revised later on. If you can get 5 to 10 years of growth, that's great. And then these children may need a formal fusion in the future.
So just a quick follow-up. So on the magnetic rods, the recommendation from the manufacturer is, in fact, after you're done growth, to exchange the magnetic actuator portion of the rod either for a straight rod or to convert to a spine fusion. There's been several papers and retrospective studies looking at what we call graduates of these growing rods. Many times we can simply exchange out the growing part of the rod and just put a regular piece of metal in place and continue having this function as an internal splint, because so many of our children are relatively low demand. But the recommendation generally up front is that at some point after age 12, when most spine growth is completed, to convert to a spine fusion. Often during that conversion process, I will address the spinal, the rib deformity that Sam was pointing out and that I pointed out by actually putting out little extension outriggers where I push up on the ribs to try to improve the thoracic volume and address the paracel rib deformity.
Perfect. Thank you both so much. So I'm actually going to jump to a question that just came in since you were referring to growing rods, and they wondered if that also, are you also referring to magic rods, or is that different?
No, so the magic rods are magnetic rods. So the traditional growing rod that was developed probably about 25 years ago, there were two versions of it. There was one where you anchored to the spine, and then there was another version where you anchored to the rib called the vector. Basically, they were sliding constructs, much like a curtain rod. And every 6 months we would go in, loosen the screw, and then we had a little distractor and we would just make the rod longer. And we would do that repeatedly every 6 months. The risk was repeated anesthetics, and that has its own complications. Then in 2014, the FDA approved a magnetic actuated rod construct where it allowed us, instead of having to do surgery, we could actually put a magnet on the back over the rod and it would rotate, and basically the turn screw had a north and south magnet and the screw would spin around. That was important in that it allowed us to eliminate the repetitive surgeries. The actuator comes in two sizes, a 70 millimeter for small kids and a 90 millimeter for larger kids. That means you can get, and the length you can gain on the 70 is about 1 inch, and on the 90 you can get about 2 inches of growth. There have been problems and recalls with the magnetic rods related to earlier versions, had some breakage of that screw that required revision. There's been some issues with wear debris, but we've seen the wear debris even with standard stainless steel constructs, and we know from total hip replacement, metal debris in and of itself probably is not such a big deal. There's also a limitation in terms of how much force this magnetic actuator can generate. And sometimes the force required to straighten the spine is more than the limited 200 newtons that the magnetic actuator can generate.
But just to reiterate, the term growing rods refers to all of these type of instrumentation. You have distraction types like the magic rods, or you have a guided growth that I described, but they're all considered growing. Considered growing rods.
Great, thank you both so much. To kind of just move, stay on the magic rods. Can you address, does the magic rods have the ability to be revised non-invasively?
No. No, I mean, because it's a physical device under the skin. It can be done as a day. I mean, when I've maxed out on the size of the distraction that I could get, it's a day surgery. In that, what I'll do is I'll leave the attachments, the bone anchors. I'll cut the rod above and below the actuator and just put in a new actuator. With little devices that attach to the old existing anchor points. We have these little connectors. And that I do as a day surgery. And often I'll time that during the time that the kids are scheduled to get Spinraza. So it's the anesthetic time is useful for both their Spinraza administration and then for my exchange of the actuator.
Great, thank you so much, Dr. Snyder. Our next question is about increased burping with a new TLSO. This individual gets G-tube feeds. There's no other concerns other than burping. Do you have any thoughts or suggestions?
Yeah, I mean, you can vent the G-tube. That's one thing. The other thing, and I think Sam's pointed this out in his talk yesterday, and then I tried to talk about it a little bit. You really have to have a big anterior window so that the belly, it almost looks like a Buddha belly popping through sometimes the hole, because you really don't want to compress the abdomen for two reasons. One is the diaphragm is so important in terms of ventilation, and you don't want to restrict that. The second is that a lot of our kids will actually get air in their stomach and either burp or you have to vent the tube.
Perfect. Thank you so much, Dr. Snyder. Our next question is, we are seeing patients that were type 1 and now after treatment are more type 2, but they are developing severe scoliosis very early, around 4 to 5 years of age. Should we consider this type of surgery segmental instrumentation earlier?
So that goes back to the study. So my hypothesis, I actually thought nusinersen and Zolgensma would actually delay the progression of scoliosis. What we had seen, even in type 1s with 2 copies with Zolgensma, we're seeing scoliosis appearing around age 3-ish. So basically, given the data that I showed you, that as long as your curve was less than 50 degrees, you sort of maintained your relationship between your pulmonary function and your stature. What I've been doing is quite aggressively putting in a growth-friendly system. I personally tend to use more of the magnetic rods. I have done hybrid systems using some of Sam's concepts as well. But the fact that I can maintain the pulmonary function relative to stature, I think is very important from a physiologic point of view. And that has allowed me to become much more aggressive about treating the spine deformity and not letting it go to 80, 90, 100 degrees, but trying to, because what we showed in another study that I didn't report here is once you started getting into 80, 90 degrees, even if I brought your curve down to less than 50, you didn't have, your lung didn't recover. The restrictive lung disease, the intrinsic lung disease does not recover. So we have started to be much more aggressive in terms of intervention. I'll start bracing very early on. I tried to delay spine surgery until the kids are at least 3 or 4 years old, if I can. You will have some practitioners who may want to instrument early. I know at Children's Hospital in Philadelphia, they've been installing vector devices in kids as young as 18 months. I've tried to delay surgery as long as possible. I think, Sam, you may have the same philosophy.
Yes, I'd like to get the kids to at least age 3 to 4 before any spinal instrumentation. And usually the bracing can delay things at least a couple of years. So I think that's always worthwhile trying.
Thank you both so much for answering that question. Moving right along, our next question we have in is, if my child has very mild scoliosis, should I still consider surgery for him? Just for reference, the child is severe type 1, 9 years old.
So severe type 1, 9 years old. So I would define what you mean mild scoliosis. So I would use the definition of, I'd use the cut point of 50 degrees. So from our data, if you're less than 50 degrees, generally you're able to have your pulmonary function stabilize and maintain what it should be for height. If it's greater than 50 degrees, you fell off that curve. If you're trached and ventilated, then probably it's a little less of an issue. So I would use 50 degrees as sort of the cut point based on our data. Sam, what's your feeling?
I don't think it's as much a number as it is documented progression. And documented progression, we're talking about 2 degrees a month type of progression. And if you're demonstrating that at 40 degrees, then I think you're showing that this is going to be a major problem. And the sooner you can stop that progression, the better off you are.
Thank you both for answering that. All right, next question we have. So this person wrote in and said their daughter, type 3, recently got a back brace. She is wearing it for 23 hours a day supposed to be for about 10 years or so. Is there any other cases out there that you know of like that? And if so, are the results positive? And then just kind of continuing, due to her back brace, she is now limited to a lot of movement with simple tasks each day.
Yeah, so I've been, so type 3, especially type 3 ambulatory children, you can sometimes approach more like the typical adolescent idiopathic scoliosis and use some of the braces that actually can truly delay and partly treat the curve. If the brace itself is actually limiting her activity, modifications to the brace design, including cutting back at the pelvic level, potentially going to more of this, what's called the Chanot design or things like that, may be helpful. But I have, in maybe about 10 to 15%, have been able to actually use the brace and avoid surgery, type 3s. And but I think you have to, you need to work carefully with your orthotist because you don't want to limit activity either. Sam, I think you like bracing as well.
I like bracing, but again, I want to document that there's progressive deformity before we initiate bracing. I often have parents come in with a child that has a 20-degree curve and says, let's do everything we can to prevent surgery. And I said, well, you know, if the child is 12 years old and we start a brace and the goal of bracing is to prevent progression, then we won't know if it's progressing or not, and the patient will be in the brace until maturity. So I like to have the curves greater than 25 degrees and document that it's a progressive deformity before bracing is initiated.
Yeah, the other thing that I'll add is there's a couple key points. One is if I'm using a brace, I try to document that the brace is actually useful and helpful. So we will actually get an in-brace x-ray, and I'm actually looking for about a 50% correction in brace. That was one of the predictors of success. The other thing is you want to document skeletal maturity. There's a number of ways of doing it. Probably the most accurate way is a left-hand film, and then you either want to look at the Sanders score or the distal radius and ulnar score. There is a scoring system using the humerus. The Risser, which is looking at the iliac crest, is probably useful, but the least sensitive and specific. But you do really want to, and another rule of thumb is, in general, peak height velocity or growth is at the time that periods come on for girls and continues in general for about 2 years after onset of menarche.
And there has been studies with idiopathic scoliosis showing vitamin D can make a difference in scoliosis progression. So I'm a big advocate of getting vitamin D levels up to normal.
Yeah. Hong Kong, they showed that, in fact, vitamin D was key, and Sam likes to use 5,000 international units and older than 11, wasn't it?
Yes. Yeah.
I tended to use 2,000, but I think too much vitamin D is probably not an issue.
Correct.
Perfect. All right, thank you both so much. This might be our last question, so we'll see. Would the magnetic actuator surgery be the standard of care for smaller children, and is it preferred?
Yeah, it's a little bit of a loaded question, and it depends a little bit on your site. So I would say, so I'm part of this whole group, this early onset scoliosis group, and I would say most sites now will use a magnetic actuated device because there's not anything out there that's actually better. I like Sam's construct a lot, but that is still gaining in popularity. The question then becomes, if you use the magnetic actuator, the next question is whether you anchor to the rib or anchor to the spine or some sort of hybrid, which is, so I would say right now among practitioners, if we look at the early onset scoliosis study section group, most people would recommend using a magic actuator. And then if there's a significant rib deformity, many folks will anchor to the spine, to the ribs. If it's more spinal deformity and not so much a rib deformity, many will anchor to the spine itself. Most folks will actually anchor distally at the pelvis because of this issue with the pelvic, late pelvic obliquity in adolescence.
I would agree.
All right, I think this will be our last question. So thank you all so much for submitting your questions. Do you have any patients that also have pectus, carnatum, or excavatum?
Yes. So that one patient that I showed, that example of the stage procedure, had a terrible pectus carnatum that actually made bracing nearly impossible. So that was one of my indications for actually, I did his growing rod construct actually at about age 3.5, which was a little earlier than I would have liked, but I couldn't brace him. So I've had 3 patients with pectus carnatum. They all got instrumented with a magic construct at around age 3.5 to 4. And I actually extended the construct up into the cervical spine using Sam's idea of these bands to allow for continued growth of the cervical spine. Pectus carnatum I have not seen so much in SMA population, but I do have a number in my more idiopathic scoliosis population, and I've also had a few in my cerebral palsy population. Sam, how about you?
Yeah, I have not seen that many in spinal muscular atrophy. The pectus carnatum is a cosmetic deformity, but it actually increases your lung space. So we don't want to compromise that just for cosmetic reasons. But if you have progressive scoliosis and you can't be braced, then that is the indication for intervention. The pectus excavatum is an issue because that does compromise pulmonary function. I have not seen that in spinal muscular atrophy, but if I did, I think that should be part of the repair.
Perfect. Thank you, Dr. Snyder and Dr. Rosenfeld for answering all these great questions. And thank you to everyone who listened in and asked questions. We truly appreciate it. Thank you again, Dr. Rosenfeld and Dr. Snyder, for your time today. Dr. Rosenfeld and Dr. Snyder also had a presentation yesterday, Orthopedic Management in SMA. If you missed it, you are able to rewatch that recording. When we thank everyone who joined in today, there is a survey linked in the session page, and you'll also be receiving a follow-up email with that survey link, and we welcome any feedback that you have to share. Once again, we are support from our sponsors for making the 2021 virtual SMA conference possible. Please be sure to join us for the 3rd day of the virtual exhibit hall this afternoon from 3 to 5 p.m. Central Time. You can live chat with exhibitors, learn about their services and products, and see what they have to offer. Also, the more booths you attend, the more times you're entered into a drawing to win a prize, and those winners will be announced Friday during the closing session. Again, if there's anything that we can do, please always feel free to reach out to us at familysupport@curesma.org. Have a great day. Thank you, Dr. Snyder and Dr. Rosenfeld. Thanks everyone for joining today.
Bye.